Thanks so much. So next, Shyam Diwakar, that comes from Amrita University in Kerala, India, is going to talk to us, and presentation is okay.
Thank you. Yep.
Have to be prepared.
First one. So, a very good morning and namaskaram. Today is in India we celebrate the embodiment of knowledge winning over ignorance. So, thank you all for this auspicious moment, and I'm very happy to be represented by Roli Mathur from India, and where India is a country of that we need to celebrate women and women's successes, and I'm very happy that I'm represented by a sister of mine. So, thank you, Adrian and Eva, to having been invited as an outlier to this meeting, and thanks to the SaIud members. I'm going to talk a little different. I know that many of you have made drugs, many of you have stopped drugs, so I'm not going to talk about pharmacogenomics. I'm going to tell you some examples that we learned as solutions to some of our problems. I come from a university. Amrita is a very young university. It's 16 years old. We are already number 8 in India, according to national rankings. And what's interesting is that we have our teaching hospital and clinical program that's top 500 in the short duration that we have been in existence. So times higher 2019 rankings gives us in top 500. Just to give you a small brief overview, we are 6 campuses in India. So many of you have been to India, have seen India in close distance, at least from the talks that I've seen, the conversations that I had. We are a very typical university in comparison to European style, where we have engineering, medicine, sciences, management, and even niche areas like agriculture. What makes us different is when I was asked to join the university, our chancellor, who's not the rector, our guiding light, gave us 3 philosophies. One being education for life, which is different from education for a living. We think students should be ambassadors of values or societal machines, and there should be enduring values that connect the world together. Every professor is asked the question, what did you do for the society, immediate society? So we are asked to look at poverty, starvation, sickness, environmental pollution, and of course contamination, and asked, can you also work on a science topic that angle? And finally, we think the entire world is one connected family, and so we need to work with global impact. So with this, I believe we got the ranking for being the most connected in India, internationally speaking. And I'm glad Adrian has visited our campus, Adrian and Eva. I'm going to skip a couple of these. Some of our problems that we want to highlight raises because of our nature of working with these 5 I's that we are talking about. Interdisciplinary, our university is by default interdisciplinary. I had some buttons to click, but I'll skip it. We introduced integrative medicine into our hospital. Our hospital is 1,300 beds based in Kochi. I think at least we have 2 visitors who know 2 of your members clearly have been in our campuses at least. So we have a very strong antimicrobial stewardship program. And what's also interesting is that we connect the hospital to work with science, with arts, and with engineers. And we have several of these centers. In fact, our nanobiomedicine group that works on drugs and pharmacogenomics is connected with the hospital more than the engineering school, which is kind of common. We also have a faculty of Ayurveda, which I might, if I have the time, I'll raise it. But what are we good at? I don't have a clicker here, but just to give you a few examples, we did Asia's first robotic DBS for Parkinson's patient, a young Parkinson's patient. And what's interesting is that it's an expensive surgery, and in fact, our organization had to take it for free. So there are questions that you would ask that would not be there in a different system. We have been very popular for what is called the multi-organ transplants. In January 2015, Indian person was trying to save a girl in a train. He was pushed to by the people from who were trying to molest that person, and that guy lost both his hands. So in January 2015, we did Asia's first non-Caucasian double hand transplant, successful. And seeing that, in March, Abdul Rahman from Afghanistan, a police captain, came back to our campus and said, "Can you do that for me? I lost my arms in an IED explosion." So you have diversity, and that's a 19 to 20-hour operation that you set it up. And that was the first 2 operations that India had seen for an arm transplant. That's when we realized how important it is for organizations like yours to actually tell people to donate not just common parts, but also much beyond. The arms is kind of there are very few people. Now we have a big network. I think a lot has been pushed into India now thanks to people. There's a lot happening. I would say we, at our hospital, because of our engineering and tendency, we built an information system that allows electronic medical records. It's not new, but it allows a patient to reduce costs across hospitals. And we give them, when they request it, on their data card, and it's up to them to show the doctor because India doesn't have a background system. I'm not going to advise or talk about India because most of you know much more than me. So I'm going to leave that to you. It works. So this is the robotic DBS. Okay, so this is 2 of them. So the 2 first subjects, 2 patients who got their lower arm double hand transplants, 2 hands connected by 1. And that's Abdul from Afghanistan. That's, I don't remember his name, but he wrote, his first thing that he did with his borrowed hand was to write thank you to the person who gave him the hand. So I'm going to skip a couple of things. We realized that India is a diabetic capital. Most of you know that. So in our School of Biotech, we started working on, this is not the pump, I'm sorry. This was when we started the project. But we have finalized a model, which I'll talk about, automated insulin pump that fits with modern cartridges. Our price range should be $35 to $65. We are working with the IT giant Wipro together on a BIRAC project funded by India to bring it out to the market. We also work on preclinical assessments. There's a strong telemedicine group that needs to actually look at scenarios where doctors can reduce the number of patients. That's one of the biggest issues in hospitals in India, where you want to have lesser number of patients inside the center. I am removing myself, but one of the works that we do in our lab is that when we went for Bihar flood relief a few years ago, our telemedicine unit, all my clinician colleagues were busy evaluating patients. It's when we realize people in India do not have very little awareness on what is called gait-related neurological condition. So we are now working on low-cost mobile phone-based sensors to look at human gait. At least can you tell a doctor or can you tell a person whether it is a neurological condition or probably just a wrong scenario. I'm going to skip a couple of these. These are student achievements. Okay, so what did we first learn from a scenario like this? The scenario of having, but this is another patient in 2017, around the same time, 2 years ago. This patient came to our hospital and said she lost her arm during a bus accident, and this is the first time that we did a male to female upper arm double hand transplant, and this is a successful case. It's running in. But what we learned out of these processes is that there are a lot more things that needs to be told to organizations or doctors or clinicians that can come from a higher level. And in fact, Dr. Subramania Iyer, my colleague here, actually published an article on what should be the inclusive and exclusive criteria for such donations. I can also say today Europe is focusing on ICT and diversity. And as a person who believes diversity is very crucial, we see that doctors are tending to work with physicians. So this is Dr. Sandeep Unikrishnan, who had to fix a few-day-old neonatal child with a rare condition where the operation had to be practiced on a 3D printed platform. So the question of whether we can ask reconstructions like this to be involved in a multi-ethnic environment is a challenge that needs to be written down or challenge to be questioned. So more of these operations are more frequent in our resource-limited settings. That kind of operation is when we realized that training clinicians are very, very critical. Not only clinicians, non-clinicians, especially I come from the School of Biotechnology. So what we did is, with Government of India's funding and with some of the top engineering institutions, together we launched India's largest virtual laboratories for skill education. So virtual labs in India means undergraduate education or postgraduate education, except that we match that for people who do not have access to classrooms. Not just, when I say no access to classrooms, I'm talking about people who want to use beyond classroom hours, which is quite common. And all of this is freely available. If you go to vlab.amrita.edu, you'll find the entire biotech collection, or on our national website, which is vlab.co.in. With students in India, young clinicians or young medicos in India, we found a bigger challenge. Our students were concerned about what not to do rather than what to do. So we started creating a virtual patient simulator called MedSim. It's funded by Ministry of Electronics and IT in India. And we created virtual case-based learning methods which are freely accessible. You can Google MedSim or search MedSim, and you might find it. And our education center started working with clinicians. This is when we realized boundaries are also limited by the data we perceive. So I believe not only is drugs a critical phenomena, we believe that everything around drugs, including awareness and education, are more critical if you need efficient field workers, especially in during of crisis. And I believe some of you have seen the crisis like Nipah virus, the Kerala floods. We have had a whole new scenario. What's interesting is that the learning platform led by Prema Nedungadi, Dr. Prema, actually runs our CREATE program. She built a Latin American, Spanish learners in America, in US specifically. She built a platform for adult learners, and that was this year's X Prize Award. That's Barbara Bush from the Bush Foundation, giving her the award earlier this year. And I had the opportunity to meet them and talk about how learning is changing communities across Latin America and Latin America. I'm going to give a few random examples, but just to tell you that I am lucky to be surrounded by colleagues like many of you who are in my own campus where we do certain things that are very fast. I'm going to skip and say what is very unique that we realized is when we started putting students to challenging scenarios. It's much more than clinicians or doctors or experts. We started seeing data from India very differently. And we call this project Live in Labs. So in our university, there is one full program, whether you're a medical student or an engineering student or a science student, you have to go to a village, live in the village with the interdisciplinary group, and learn from this group. And I believe this aligns with SIOM's double perspective. The other ways of thinking, I loved it. So I think it's important that some of you who are thought leaders, policymakers, allow diversity support, as I was talking to yesterday to some of you. And it's important that younger people have an inspiration to learn what are the problems, but the problems need to be seen by their own eyes. In fact, I'm going to just say that we send them as a group of students. We allow international students to join us. We have Harvard Public Health sending 20 students, Tokyo sending 60 students a year, and we send them as a team. They live in the village. They either identify a problem, if it's a very short visit, 2 weeks. If it's 3 months, they try to design a solution. They usually, being academic, of course, we give them credit by saying, make it published or make a publishable version so it's reusable. And our NGO, if it's a great idea, implements in the field. And I'm talking to you about some of these very interesting SDG areas, Sustainable Development Goal areas, like a few of these. And I'm going to not talk about this, but I can give you a set of examples. In 2017, we launched India's largest clean drinking water project as an NGO. This is the President of India, Sri Ramnath Govindji, launching Jeevamritam, which is clean drinking water. What we didn't realize was we thought water was an issue, but what we found out was water-related issues plague Indian villages or Indian communities, and clinicians need to be very aware. We were concerned about water contaminants. We were concerned about antimicrobials, microbials in general, and we were concerned about how these problems can be solved. And these were problems that were identified by students and not by professors. I mean, there's a faculty group. And just to tell you, Live-in Labs, we did a few examples. These are those that are deployed in villages. By the way, the Live-in, our parent organization, which runs a charity called Embracing the World, has adopted 150 remote villages, communities in India, and our students have full access to them. So as faculty members, as students, we go as interdisciplinary groups, and we allow universities from abroad to join us, or also people from abroad to join us to implement some of these problems. I'm going to avoid this. This is a nice story that came from EPFL, Amrita. We are looking at teaching pedagogy, health awareness, open defecation-free environments. We have graduated 3,000 women plumbers, 8,000 women plumbers, out of which 3,000 happen in a single year using a skill development, computer-enabled skill development program. So now I'll come to a very simple question. So one of the things that we found very interesting is that we have a faculty of modern medicine, conventional medicine, and a College of Nursing, a dentistry, and pharmacy in our Cochin campus. And we have a school of Ayurveda that does both bachelor's and master's, MD/MS in Ayurveda, looking at Ayurveda as a method of working. And of course, we do not say that patients have to do this or that. It's up to them, their choice. And we always find that people who come to Ayurveda do have a different approach compared to those of general medicine. But there are problems that we have seen that are very innovative when it comes to Ayurveda. So our phytochemistry group has been working with single herb Ayurvedic medicines to look at common causes. We call this the wealth from waste problem. So in India, fishermen in Kerala, I live in a fisherman's village called Amritapuri. So fishermen in Kerala, when they have a diabetic wound in the past, they would apply what is called, they would heat the cashew nut seed, the outer envelope of cashew nut, and use it as a medicine on the skin, typically anacardic acid. So our groups this is a collaboration with California, San Diego, UC Riverside, and Amrita together. And now this has given up to our new collaboration. We have established what is called the Tata Institute of Genetic Studies in collaboration with these partners to look at some of these scenarios and, coincidentally, some of those other cases. I'm going to skip this. This is all research studies by my colleagues, and I've taken the eye out of this picture. One of the other big scenarios that we handle is we look at diseases and conditions that arise out of water. As Jeevamridam is connecting all these villages with clean drinking water, by the way, we have some support studies from Tel Aviv, Ben Gurion, who are actually working with us in 220 communities in India implementing the clean drinking water project as well. We think countries like India, as experts like Rowley could tell us even better, that urban populations will have much diverse problems that are related to water conditions. And whether last year we had Kerala floods, and as many of you would have heard about it, we survived Kerala floods because we had social media. So in fact, Army and Navy did a great job. The National Disaster Management System did a great job. But we as a university had to volunteer. I remember 7 days we had to volunteer 24 hours as a call center to receive the calls. And I remember my PhD student crying when he received a call from Germany. A student in Germany was telling him his mother is floating and his younger brother is holding on to the body. It was in Idiki. But this is the kind of scenario. So we think it's critical that some of you keep this larger perspective of not just data, but the diversity that comes from data and the ability to allow very diverse groups to work with data, not just the drugs. A colleague, so for example, when India had the toilet challenge, Reinvent the Toilet Challenge from Bill and Melinda Gates Foundation, one of my colleagues, Sanjay Pal, actually, along with a couple of others, started looking at the lytic system. So he uses bacteriophages to fight bacteria. So we think, at least in India, we have a feel that nature is a great teacher. So we look at some of the natural cues to identify how we can cut costs, at least in our settings. So for example, we've been working with bacteriophages in malodor systems. We've been looking at disseminating lytic agents. And now we're looking at entire drug history related to some of these pathogens. And I think I'll have to speed up. But the very critical part of it is that drugs alone don't help. Monitoring and awareness do a lot more. So in fact, we believe that it's industry, it's academia, it's communities of people, it's everyone who should come together. But as an academia, we facilitate that process by looking at, let's say, we developed a patent, we patented a US, we applied for a US patent, and we won it in 2013 for our insulin pump, a low-cost insulin pump, and a low-cost non-enzymatic sensor strip. The idea we patented is we wanted it to be low cost and to be protected from expensive phenomena. But what we did is we went to the government. Of course, we worked with an industry. We are now launching it probably in 2020, a low-cost insulin pump, which will be called, I think, Ampro, Amrita Vipro. So Ampro device, which will come to help monitor data. And we think that will create a huge diversity of patient monitoring data as well. So this is going to be a challenge. We might need informaticians, we might need policymakers, we might actually need clinicians to adapt to these kind of scenarios. This is my very last slide. Yesterday I was talking about publications too, and one of the things that India faces is we are constantly told publish or perish, right? So we think, although it's not a great message, I think some of your ideas that you take for policymakers, a policy system, we believe that when you put context like medicine into our heads, please remember that would be very interesting if you can make it consider a sustainable future. We think time is a big factor, and we want you to play with, tell us what time scales we can think about, we can dream about. A couple of years ago, let me pull a small example in Bihar, in one of the villages called Ratanpur. Our women empowerment group, we have UNESCO chair in gender equality and women empowerment, the Asia's first. And Dr. Bhavani's group, when she went to this place and started training women, new literate women, to build toilets, they built a couple of toilets. We took pictures, we were very happy. But what was interesting is that they never used the toilet. So our second group of students found out that they were using it to store grains inside the toilet. So we asked them, what is the reason? So these women were blushing, they were talking. So later, since women empowerment is led by women, some of our students, girl students, went and told, "Boliye ji, kya hai? What is the problem?" And this lady said, this is the only time in India where we are away from our husbands and family. So it might be critical to, when you design policies, to involve socio-cultural context. I'll tell you the solution we did. Our chancellor, being a woman, she even suggested a communal kitchen right in the center. On the periphery of the village was the toilets, common storage area, and a communal kitchen. Now, that's the meeting. And what is interesting is that Ratanpur's panchayat leader, the leader of the village, is one of our new learners from the tablet program. So this is very critical when you think about how solutions can be developed. And I would not ignore and say we are trying to do the same in Kenya, in Nairobi, close to Nairobi, in Watatu Boma. So it should be compatible. One of the things that I always think is being forgotten is technological interventions. And finally, please be, which I don't have to tell you, I'm glad you tell me, that this meeting is about resource-limited settings and economical affordability. And thank you very much. I'm here anyway.
Thanks so much.